Welcome back to the Cribsiders. This is a Medscape video recap summary of one of our most recent podcast episodes. Today we're exploring pediatric acne. Chris, can you tell us who's guiding us through this topic?
We have the pleasure of speaking to Dr. Brandi Kenner-Bell, an assistant professor of pediatrics and dermatology at Northwestern and Lurie Children's Hospital, who shared her vast knowledge on pediatric acne.
Wow, that's impressive. Dr. Kenner-Bell shed light on how acne varies across different age groups, and are they classified any differently?
Yeah, that's a really great question, Jess. Acne classification based on age helps us tailor our approach to treatment, considering the unique challenges and needs to each stage of life. So first is neonatal acne. This is the birth to 6 weeks of age. This type of acne occurs shortly after birth and is believed to be caused by maternal hormones still circulating in the baby's system. It's characterized by small red bumps or pustules in the cheeks, nose, and forehead. Neonatal acne is generally mild and resolves on its own without treatment. Next is the infantile acne, which is the 3 months to 1 year. Unlike neonatal acne, infantile acne may be more pronounced and can include blackheads, whiteheads, even inflammatory lesions. This condition is thought to be influenced by the infant's own hormonal changes, although it often resolves spontaneously. Severe cases may resolve pediatric dermatologist's attention to prevent scarring. Next is the mid-childhood acne, which is ages 1 to 7. I'm going to get back to that later because it's a little more complicated. After that is the pre-adolescent acne, which is ages 7 to 12. Here we start seeing the early stages of puberty-related acne, primarily open blackheads, closed whitehead comedones, mostly appearing on the forehead and midface. This is due to the beginning of hormonal changes that stimulate oil production. Last, we have the adolescent acne, which most of us know about. This is ages 13 to 18. This age group sees a broader range of acne severity from mild comedonal acne to more severe forms, including inflammatory lesions like papules, pustules, cysts. Adolescent acne is more widespread, affecting the face, chest, back, and driven by peak hormonal fluctuations and increased oil production. So understanding sort of these classifications helps us really anticipate the patient's needs and potential response to treatment, and really makes our management strategies more effective.
Interesting. So there is really a difference based on age. I noticed you skipped over mid-childhood acne. Can you tell us a little more about that?
Yeah, mid-childhood acne is a little more complicated. This happens between the ages of 1 to 7 and can occasionally see underlying health issues. So Dr. Kenner-Bell shared some of her expert approach to managing acne in this age group. First and foremost, Dr. Kenner-Bell advises a cautious approach to workup for the children under 2 years of age, recommending that extensive investigation should generally be deferred unless acne is notably severe. This approach helps avoid unnecessary interventions in the very young, where acne may resolve on its own or with minimal treatment. For children presenting with acne but without any abnormal physical findings such as absence of breast buds, pubic hair, or clitoromegaly, Dr. Kenner-Bell suggests starting with an assessment of bone age. This initial step is less invasive and can provide valuable insights to a child's growth and development relative to the chronological age. Should the bone age study indicate advanced bone age, or are there other signs of precocious puberty or hormonal imbalances, further labs and evaluations may then be warranted to explore the underlying causes. This careful stage approach ensures that investigations are tailored to each child's specific presentation and that more invasive tests are reserved for when they are truly necessary. In essence, her expert opinions really highlight the importance of balancing vigilance with prudence in the evaluation of mid-childhood acne by focusing on the most telling indicators and proceeding with further work only when indicated. We can ensure that our young patients receive the most appropriate and effective care.
So given all these variations, how do we approach first-line over-the-counter treatments?
For acne across various age groups, it's essential to start with the basics. So a gentle skincare routine, including mild cleansers and moisturizers suitable for sensitive skin. This sets the foundation for any acne treatment by maintaining a skin barrier integrity and reducing irritation. For active treatment, we really recommend beginning with benzoyl peroxide and salicylic acid. Benzoyl peroxide is effective in reducing inflammation and killing acne-causing bacteria, while salicylic acid helps unclog pores and prevent new lesions. Both are variable in various formulations and concentrations, allowing for customization based on patient's skin type and tolerance. An important addition to our first-line over-the-counter arsenal is topical retinoids. Over-the-counter options like adaptolene gel have revolutionized acne treatment by being accessible without a prescription. Retinoids work by promoting skin cell turnover and preventing plugging of hair follicles, which can lead to comedones. They're particularly effective with both comedonal and inflammatory acne and have added benefit of improving skin texture and reducing post-inflammatory hyperpigmentation. When discussing all of these treatments with patients and their families, it's really crucial to emphasize patience and consistency. Acne treatment is a marathon and not a sprint, and improvements can take several weeks to become noticeable. So side effects such as dryness and irritation are common, especially within the initial weeks. We advise starting any new treatment slowly, perhaps every other night, and gradually increasing as tolerated, in addition to using moisturizer to mitigate these side effects. Lastly, over-the-counter treatments can be remarkably effective for mild and moderate acne. It's important for patients to know when to seek further medical advice. So if acne is severe, worsening, or not responding to these treatments, it may be time to consider prescription options or even referral to a dermatologist.
Perfect. So it sounds like over-the-counter treatments is a good place to start, but for some kids, though, those really aren't enough. So what other additional therapies does Dr. Kenner-Bell suggest?
So when we step up to oral therapies, it's mostly oral antibiotics like doxycycline or minocycline. They're often used for the anti-inflammatory properties, but for patients with significant hormonal influences, oral contraceptives or anti-androgens like spironolactone can be beneficial here. In cases of severe scarring acne, isotretinoin may be considered.
It's clear that treating acne involves a pretty comprehensive understanding of the various different presentations, and really you need to have a thoughtful approach to therapy. Thank you, Chris, so much for this thorough overview and review. To listen to the full episode, you can download this episode and others on any podcast player or check out our website, www.thecribsiders.com.